I'm going to have everyone introduce themselves. Dr. Provost, do you mind going first?
I'm Dr. Meredith Provost. I'm a reproductive endocrinologist and infertility specialist in Indianapolis, Indiana. So I see a lot of PCOS in my practice, both in people trying to get pregnant and then in just managing symptoms in patients experiencing it.
Thank you. Dr. Gupta?
Hi, I'm Ashita Gupta. I've done my fellowships in adult endocrinology as well as integrative medicine at Dr. Andrew Weil's program. So I practice integrative endocrinology. My practice is in New York City, and I have a special focus on thyroid disease, all kinds of thyroid disease, and women's health. So again, PCOS is a lot of what I see in my practice.
Awesome. Dr. Zubritsky?
Hi, everyone. My name is Dr. Lindsey Zubritsky. I'm a board-certified dermatologist, and I'm in private practice in Pittsburgh, Pennsylvania. As someone who sees skin all day long, I'm one of the frontline people for PCOS. I'm one of the first people to diagnose it, and I treat multiple different modalities of PCOS. So I'm excited to be invited here tonight. Thank you for having me.
Yeah, thanks for being here. Dr. Talib?
Hi, my name is Dr. Hina Talib. I am a pediatrician and an adolescent medicine specialist, and I work here in New York City, and I feel like my days are just filled with treating and diagnosing polycystic ovary syndrome in adolescents and young adults. So I'm at the sort of beginning stages of where the condition starts, and I'm happy to share with you guys.
Thank you. Dr. Gerber?
Hi, how are you? I'm Dr. Rachel Gerber. I'm a reproductive endocrinology and infertility doctor in New York City, and I also see a lot of PCOS, deal primarily with fertility and reproductive health, and I'm happy to be here.
Awesome. So we're going to jump right in. So I know you guys already probably know a lot about PCOS as attendees to this, so you're clearly very interested in it. So we will let you sort of Google the basic definitions, and we want to get to some of the questions that were asked. You can also use the Q&A feature to ask questions, and we're going to sort of start off with a question for Dr. Talib and Dr. Gupta, and everyone else feel free to jump in. But what hormonal test should my doctor order to help diagnose PCOS?
Sure.
Dr. Talib, if you want to go first.
Yeah, sure. So PCOS, I think one of the reasons why maybe there's so much interest in us getting together is that, especially in the younger age groups, there isn't 100% consensus in how everybody approaches diagnosing the condition and even defining the condition in especially the really younger ages. And so so answers may be different depending on how people practice. But in terms of the lab, you asked about the lab tests that we might do. So certainly basics that we would do are looking for androgens, which would be your free and total testosterone, your DHEA, and your androstenedione. And so those would be markers for hyperandrogenism, which would be indicative or, would help us make the diagnosis of polycystic ovary syndrome. But we also want to check LH and FSH. And so basically now we're going to be ruling out or considering other things. So we want to make sure your ovaries are working. You want to make sure that we don't have thyroid disease. We want to make sure that we don't have late onset CAH, a congenital adrenal hyperplasia. And you'll have some docs who will test that right up front and some docs who won't test that right up front.
And what makes a doctor test that up front versus not test it up front?
It's variable in how folks practice, but if you feel like you have a history that fits late onset CAH, you do. The way we generally practice in my group is that we initially will almost always screen for it to really be confident in our diagnosis.
Okay, awesome. Dr. Gupta, anything to add?
Yeah, I think, our focus with Dr. Talib's patient population and mine are a little different. So a lot of times patients have already come to me, and CAH screening is kind of secondary because I'm seeing an adult population. But that being said, hyperandrogenism or the imbalance in male hormone is like the hallmark of this condition. So when I will test DHEA, testosterone, LH, FSH, like the ovarian group of hormones, the sex hormones, but I also test some of the androgenic hormones coming out of the adrenals, like androstenedione or 17-hydroxyprogesterone. I might consider throwing those in there as well, in case there's just to try to figure out where is the source of the hyperandrogens coming from. Is it the ovaries versus the adrenals? Chances are it's the ovaries, but as Dr. Talib was saying, just to make sure we are targeting the right organ.
And why is that important? Because if it's the ovaries, that means it's indicative of PCOS?
Indicative of PCOS, exactly. Only the ovaries can make excess testosterone. So if that's what you're finding, everything else is okay, then you're treating PCOS versus congenital adrenal hyperplasia, some adrenally mediated hyperandrogen situation.
And is that because they present the same way? Like you can get hair growth?
They can present the same way: skipped periods, irregular periods, hair growth on the face, acne, infertility, but the treatment approach may be somewhat different, so different topic, different time. But I would do that in the initial workup. I also, as a practice, do the full thyroid panel because a lot of women with PCOS will also have Hashimoto's, particularly if they have a family history of thyroid disease. So it's good to get that screening done right away. And then the thing that I want to emphasize very strongly here, which a lot of people miss, I think, with PCOS, is the element of insulin resistance that comes with PCOS. So as part of my initial screening, I will test for that as well. Blood sugar screening, insulin markers, maybe an A1C screening, particularly if the woman also has issues with weight gain, obesity, family history of diabetes or prediabetes. It's very important not to miss it because that can influence your treatment plan tremendously.
So actually, I was going to ask this a little bit later, but you did mention it. So there were actually several questions that came up in the form that we sent out to everyone about insulin resistance, its relation to PCOS, and also several questions about metformin. So I'm going to leave the floor open to anyone who wants to start taking that question. So how is it, I guess to start off, what's the relationship between PCOS and insulin resistance? Dr. Gupta, you want to start?
I don't mind sharing. I just wanted to give everybody else a chance to speak if they have something to say. But yeah, it's a little bit of a chicken and the egg situation. So we don't know, there's a lot about PCOS we don't understand. We don't know if the hyperandrogenism is driving the hyperinsulinism or vice versa. But the one thing that we can all agree on as physicians is that both pathogenic processes are there. You've got excess male hormone production, and you've got this underlying resistance to insulin. So when you want to treat PCOS adequately, you need to address both. I guess, you were asking about metformin, whether or not to use it. I mean, that's going pretty far out, but yes, everybody has insulin resistance, if that's what you're asking, if they have PCOS, whether you look like that textbook definition of PCOS where you're obese or overweight, that phenotype accounts for about 50 to 60% of PCOS cases. But what about the other 40 to 50%? Those women are what we call the lean PCOS. So they're not overweight or obese. They might have a normal BMI, even a low normal BMI, but there still is that element of insulin resistance, even in women like that.
Yeah, from a reproductive standpoint, I think that PCOS really is a disease of insulin resistance, and all of the everything that we see around it kind of results from that. I think that insulin resistance is what driving that testosterone production that we see in the ovaries that yields all the symptoms that we see. But it's really important to understand that insulin resistance underlies it. And insulin resistance is a complicated concept. And it's really not something that we can test for well in the medical field. So there's kind of three things. And because I get a lot of patients who are like, I don't have diabetes. Why are you telling me I have insulin resistance? And there's diabetes, and we can test it whether or not your sugars are out of control at all times. There's glucose tolerance. If you have something sweet, does that make your sugar spike higher than they should? But insulin resistance is really something that we can only test in an experimental lab where we make you euglycemic and do all these scary things that we can't do in the general population. So we just have to kind of assume that these patients with PCOS have this insulin resistance because we know that they're so related. And we want to screen for all those other things that can be sequelae of PCOS, but understanding that that is there for even our thin patients or our overweight patients is really essential to understanding how to treat the disease.
Can I add something about the insulin resistance testing?
Yeah.
Because that is so important, for all of our practices. For me, what makes me suspicious, I mean, all the women that have PCOS will have some element, but what makes me even more suspicious is when a woman might say, I tend to feel like shaky or sweaty, or I have headaches like after my meal. I feel really tired an hour after I've eaten, and I know I've eaten a good enough meal. Why is this happening to me? And if you dig a little deeper, you'll see that it's all tends to happen more with high carb meals, like a bowl of pasta or oatmeal. Like an hour later, they're feeling like, hypoglycemic symptoms. Sometimes they'll wake up restless in the middle of the night with a headache, feeling hungry or thirsty. And, those are signs that there's these insulin spikes and sugar crashes happening through the day, unevenness in the energy. They might have a family history of diabetes or pre-diabetes. So that makes you suspicious. And as Dr. Provost was saying, there's very strict specific criteria for pre-diabetes and diabetes, specific tests, specific blood sugar intervals that we're looking for. How do we test for insulin resistance? So if I could share what I do in my practice is that I'll have the patient do the blood work. Sometimes I'll say, let's do it fasting. And sometimes I'll say, go eat a nice big carby meal, have fun, and get the blood work done in an hour. Let's see what your sugar looks like. Very often my screening will be the initial fasting glucose. And if their fasting glucose looks normal and their A1C looks normal, a lot of times women will say, I've had my sugar tested. It's normal, as Dr. Provost has seen. My sugar is normal. But if the sugar is normal, and I see this so many times, the fasting sugar is normal, the A1C is normal, but you check a C-peptide, which is a marker of your own body's insulin production, and it is above normal. Normally, when our sugar is low, because we're fasting, we haven't eaten yet, our insulin is supposed to be matching that low. And when we eat and the sugar goes up, your insulin goes up to match it. So why is it that if my sugar is low, why do I have this insulin level that's not matching? It's slightly elevated. That is a sign of insulin resistance, because you've got this baseline plumped up level of insulin floating around all day long, and it further spikes when you've eaten. So that's how I try to pick it up on initial blood work.
So is C-peptide part of that initial workup then usually?
I do. I always do a C-peptide, yeah.
Okay. And that's just the blood draw.
It's coming out of the same tubes anyway, so.
Okay, awesome. I want to switch gears a little bit here because you guys had mentioned a lot of these things, but for Dr. Provost, what are your thoughts regarding supplementation for PCOS, and has it been shown to help at all with symptomatic PCOS?
Yeah, so I mean, when you're talking about supplements, you're talking generally about smaller studies. So first thing to understand, we're not talking about big randomized control trials with a lot of data. And generally, we're looking at supplements that are going to affect that insulin resistance. They tend to be antioxidants or medications that we think can help with insulin resistance. So there have been some smaller studies that have been somewhat promising in this area. Probably one of the best known ones is myo-inositol. That has been shown, and obviously other people weigh in if they've got thoughts on these too, but myo-inositol can be helpful, as well as like alpha lipoic acid is another one that I often use in my patients. Both of them can help some with that blood sugar. Obviously we talk about things like metformin and whether to use them at the same time, and there's a whole discussion that can be had with all of these. I often find a lot of my PCOS patients are vitamin D deficient too, so I check that in pretty much everybody.
Yeah. And that's the PCOS causing the vitamin deficiency, not vitamin deficiency contributing, right? Because PCOS is
I think there's like vitamin D is associated with insulin resistance. So, if you've got low D, why not supplements? A very easy one to fix. But yes, like in terms of supplements, and there's a lot, I don't do as much work for fertility planning, but for me, when I'm advising patients about supplements with PCOS, it's more for just their general PCOS optimization. I will say that, of the two processes happening here with insulin resistance versus hyperandrogenism, it is hard to find natural supplements that really work for the hyperandrogenism. And I warn patients about that from the get-go. If they've got hirsutism, especially hirsutism, which is very challenging to treat, or acne, for instance, that's driven by a high testosterone, and they don't want to take medications, I'll give them a heads up. There's options like saw palmetto or D-chiroinositol that are sometimes used in, as Dr. Provost says, as smaller studies, mixed bag of results. I don't find them that reliable to actually lower testosterone levels, but there are a lot of supplements that could be used more successfully for the metabolic syndrome or the insulin resistance arm of it. So I usually, if someone's more keen on diet, lifestyle, natural approaches, I'll advise them more on the metabolic side of things, because those can be very effective. And typically the best result is with a balanced approach between diet, lifestyle, supplements, plus probably a prescription drug, depending on what kind of symptoms you have.
Dr. Zubritsky, I'd love to hear your thoughts on some of the, Dr. Gupta just mentioned the hair growth and acne. As a dermatologist, I'm sure this is something that people come to you about. Like, what are some of your initial thoughts when you have that patient that has just like stubborn acne and like frustrated?
Right. So, like I mentioned when I was introducing myself as a dermatologist, I am one of the first people actually to diagnose PCOS, because people don't realize, they don't know what's going on internally, and all they see is the external features. So I have that very unique opportunity to, be the first one to put into their head, hey, I think you have a diagnosis of PCOS, and get them connected with endocrine and OB-GYN and fertility and everything. So it's definitely something that I see quite a lot. And unfortunately, the kind of acne that people come in with if they have PCOS is already pretty severe. And as Dr. Gupta had mentioned, a lot of people, they do want to try natural things and lifestyle changes, which of course is a huge aspect of it and is very important. But there are definitely reasons that we give the medications that we do, and they're effective. And you do need something a little bit more than topicals, for example, to help with the severe acne that these patients come in with. So typically what we'll use in the clinic is a combination of oral contraceptive pills, spironolactone, and even isotretinoin if needed. But the acne can be so severe, and the issue with waiting to see if topicals work or other natural things work, or if diet and exercise work, is that the longer that you wait, the more scarring that you're going to see, the more long-term issues you're going to have from it. So acne isn't just a cosmetic thing. If you have severe nodular cystic acne, like many people with PCOS do, that can be a lifelong problem. First, that it doesn't go away on its own if it's not addressed. And second, like I mentioned, it leaves behind tons of acne scars and divots and atrophy and marks. And that could be very devastating to someone's psyche.
Yeah, no.
I'll just add that for young people, for adolescents and young adults, this can be especially as they're just embarking on puberty and coming out of puberty. This also has a major quality of life and mental health, mood, anxiety, depression components to it, and it just compounds. And so it certainly can be one of the presenting signs, along with menstrual irregularity, whether that be skipped periods or whether that be a big heavy bleed that comes after a period of not having periods. But we really want to not discount the importance of these cosmetic changes that they might be, seeing, as well as the hair thinning, which is another one that has, it really affects them, because they are at a time when they're comparing themselves to their peers a lot. They're developing their own sense of self, their gender identity, their sexual identity. And so it all kind of comes into play, and we certainly want to give it its due and treat those, treat so that we, where I'm at, I try to prevent it from getting to a point where it needs more aggressive skin treatment. But sometimes they present to us, and it's already at a point where it's considered severe and cystic, and we really are worried about scarring and other things like that. But it's important. I don't want anyone to discount that part of PCOS, especially in youth.
Yeah, I mean, I don't have PCOS, but I remember getting really bad hormonal acne when I went through egg freezing a few years ago, and it was like, I was like, I'm already single. I was like, now now I have to deal with this. So I didn't really go out a lot. Anything for the hair growth that you would recommend, Dr. Zubritsky? I mean, or does spironolactone do that, or?
So when we talk about PCOS and hair, we have to consider two different things. So first, they have hirsutism, so they have excess hair growth. And then second, unfortunately, on top of that, just to make matters worse, you lose hair where you don't want to lose hair. So these females with PCOS, they can develop female pattern hair loss or even male pattern hair loss. And they're similar, but they're a little bit different. It's just the pattern that it looks like. And the female pattern hair loss is where you start to see a widened midline part, you start to notice diffuse hair thinning all over, or the male version is when you look like a balding male, essentially. You lose it in the vertex of the scalp, your hairline starts to recede, and you get like bitemporal recession. So when we talk about hirsutism, that's excess hair growth, where vellus hairs, which are usually like those peach fuzz hairs we see on our skin, turn into terminal hairs, which are thick, dark, coarse hairs that women typically don't have, so you'll see it along like the chin and the mustache area. You'll get it on the neck, the abdomen, the back, more pubic hair. So both of those can fortunately be treated essentially in similar fashion, but they each do require their own different treatments as well. So like you mentioned, spironolactone is a great place to start. It helps to regulate those hormones, and it's an anti-androgen, so it's going to decrease that androgen excess, and that's going to help the hair grow and in the places that you want it to grow, and it's going to help decrease the hair in the places that you don't want it to grow, in addition to oral contraceptive pills. But when you're talking specifically about removing hair, there's a few other things that you can do. Essentially, lasers are a great option for that. Just make sure you're seeing a board certified dermatologist, not just going to any med spa, because someone could just sell you a laser and really damage your skin, especially if you're a person of color. It's not safe to just have any laser hair removal done. So that's one of the most permanent things, the most effective things. But there's also a topical cream called Vanica that's a prescription that we recommend sometimes. But if people don't have that kind of funds or money or anything in their budget for those more expensive things, you can always wax, shave, all those things, just as long as you're doing it safely.
Is the myth about shaving true, that if you
no there's nothing that can affect I mean, when you're shaving, you're just essentially going across the top part of the skin, and it's not affecting the hair follicle at all.
Okay, so it won't come back thicker and darker. Okay, I'm definitely a victim of that. All right. This question is for Dr. Gerber and Dr. Provost. What are some of the things that someone with PCOS needs to worry about, and in terms of their fertility, and options for preserving fertility, or just, is there something they can do? Diet, lifestyle, obviously, cryopreservation of their eggs. Would love to hear your thoughts on just how someone with PCOS should be thinking about their future fertility. Dr. Gerber, if you want to go first.
Sure. So, the primary way that PCOS affects fertility is by something that we call anovulation, which means that, you're not releasing an egg at a regular interval. So normally, in regular cycles, people have periods every month, and you can, through testing or just through having regular cycles, you can time intercourse in an effective way. So you might know, okay, my cycle's 30 days. I know I'm going to ovulate about mid-cycle, so I know when to time intercourse to appropriately get pregnant. So, first of all, some patients with PCOS do ovulate, but it's not at a regular interval, so it won't be every month, and therefore you don't know when to time your intercourse. And even using things like ovulation predictor kits can be difficult, because sometimes they're always positive because of the hormonal changes that are part of PCOS. And also you don't know when to test. So you could go for months and, ovulate after 3 months, but by then you've gone through 10 packs of kits and you've been doing it for 60 days. And you're not going to continue to do that for an endless amount of time.
Practical.
So exactly. So because of that, even if you do ovulate, it becomes very, very difficult to time intercourse around that. But, on the other hand, some people really don't ovulate at all. And ultimately, if you don't release an egg, that's you can't get pregnant, right? So the really good thing is, from our perspective, is that we have really good treatments for this that are what we call, very non-invasive. They're not expensive, and they're things that can even be done at home without a lot of doctor's visits and a lot of intervention. And those would be to start with oral medications that help the body ovulate. So it kind of tricks the brain into setting off that cycle to ovulate that is missing in patients with PCOS. And then often we can sometimes start at a low dose and start slowly and figure out what dose is right for you. And in most cases we can effectively get patients to ovulate and have a really good chance of getting them pregnant with simple medications that are taken orally.
What are some of those medications?
So there's two. One is a little more well known. That would be Clomid, is something that people have heard of, and it's been around for longer. But actually, in the last 10 years, there's been a new medication called letrozole, or Femera. And, studies came out really showing that actually has a increased rate of ovulation, a better pregnancy rate, and a lower twin rate. So the fertility world really considers letrozole first line, even though I think the general gynecologists seem to be more comfortable with Clomid because they have more experience with it and tend to probably prescribe that first.
And you had mentioned getting your ovulation cycles regular. Is that something that, like, what if you're like years away from having a child? Should you still be getting your ovulation cycles regular with letrozole or Clomid?
Not necessarily. So
Okay.
women are supposed to have periods at a regular interval. That can range from every 25 days to every 35 days, but for women, it should be coming within a few days range, predictably every month. If they are not, then that's kind of a vital sign that something's going wrong with your reproductive health and lifestyle, and it's something that you should get checked out with your physician, whether it's your pediatrician, whether it's your gynecologist at that point in your life. If you're going long time without a cycle, then that's actually something that can be over time dangerous. If you are not fully having a period and shedding your entire lining, and that's going on for more 3 or 4 months at a time, that actually can put you at a higher lifetime risk of badness like endometrial cancer. So that's definitely something that you want to manage. Now, taking medication like letrozole to get you to ovulate is not necessarily the best way to manage your cycles over long periods of time when you're not trying to conceive. That's usually something that we'll save for when someone's ready to be actively trying to get pregnant. Okay. Generally, prior to that, we're looking at lifestyle changes and or oral contraceptive pills or other types of birth control.
Okay, awesome. And
I just would like to add that if you're taking, there's certain medications that you can take to help, prevent this overgrowth of the uterine lining that actually could stop your period for long periods of time. Something like a hormonal IUD, or taking a continuous, birth control pill, or, the Depo-Provera shot. And it's okay not to have a period if it's due to the medication that you're taking to protect the uterine lining. So, what we are afraid of is when you're not getting a period and that's just what's going on at a baseline without any medication. But if you're taking medication that's protecting the uterine lining and then you're not having a period, that's considered safe and a healthy way to prevent any of these complications with the uterine lining and potentially developing an endometrial cancer.
Yeah, no, thank you so much for that. I just want to reset the webinar real quick. We have had about 20 more people join us since we started. So just going to quickly introduce everyone again. Dr. Meredith Provost, she is a REI specialist based out of Indiana. Dr. Ashita Gupta is an endocrinologist in New York City. Dr. Rachel Gerber is an REI specialist as well. She's based in New York, soon to be seeing patients in Westchester, actually. Dr. Hina Talib is a pediatric and adolescent medicine specialist. She's also based in New York City. And Dr. Lindsey Zubritsky is a dermatologist who practices in Pittsburgh. All of their handles for social media, Instagram, TikTok, are in their Zoom profile in the lower left-hand corner. So if you guys want to go ahead and give them a follow and check out some of they're always educating online, so you can go ahead and check out their content. But I'm going to get back to this. We have a lot of questions in the Q&A. I was trying to address some of the questions that had come in through the form, and I saw Dr. Talib going in and answering some of them. And if any of the other panelists want to go through and answer some of them through typing, please feel free. But I'm going to try to start addressing some of these. Alternative medications are there any alternative medications for PCOS? What is prescribed the most and what has helped the most? So I guess the question here is there any data for non-traditional medications? So I guess maybe supplements, any good data? I know we had mentioned one earlier.
Well, I can talk to some of that. Like I said, most of the supplements that you can buy over the counter are addressing PCOS from the insulin resistance standpoint. That's what works most effectively. I would say at the very baseline, diet and lifestyle are key. So that's, free. Basically, you don't have to buy anything. You don't need a prescription for, and it's important for management of PCOS because this is a long-term condition. I think it's important for people to understand it's a syndrome. It's with you for your life, and it might manifest different ways at different parts of your life, depending whether you're a teenager or a young woman of reproductive age or post-menopause. So your needs might change, but it's important to be on top of it. So what kind of supplements you take also might change over the course of time, but diet and lifestyle needs to be a constant where we talk about that separately. I think the question was specifically about supplements, but I just want to emphasize the supplements are secondary and medications important, but also secondary to you working on diet and lifestyle primarily. So some of the common ones that have some data, there's mixed data, smaller studies for a lot of these over-the-counter things, but I think it's important to note that also besides traditional medicine, the other forms of medicine like whole systems, as they call it, like Ayurveda, traditional Chinese medicine, has their own ways to address it. And a lot of those are supplements that we use now, like in Ayurveda, bitter melon, gymnema, cinnamon, fenugreek have been commonly used to treat diabetes or pre-diabetes or insulin resistance. And that's a lot of what we use now.
What would you
for
say is
PCOS.
Probably one of the most popular, if you had to give like one or two thoughts?
I would say berberine probably. I would pick berberine because it works the most like metformin. It's very similar, and you take it with meals, and a lot of people will feel this similar effects and side effects as metformin, where they feel like their blood sugar is steadier through the day, less sugar craving, less sugar spikes and crashes.
And of course, if you guys are taking any supplements at all, you need to make your doctor aware, because supplements can have effects on other blood levels. I'm not an expert in all things supplements, but I do remember that it can, mess with some of the other things. So this is not something to do without a doctor involved.
And berberine, for instance, is one of those where you ideally should not be taking it during pregnancy, whereas metformin you can. So berberine is a commonly used one. I feel like one of the easiest supplements to use is probably cinnamon, which also helps lower insulin resistance. It's not much, like 1 gram or half a teaspoon a day, so you don't necessarily have to have that in capsule form. Even just good quality cinnamon powder somewhere in your coffee or your breakfast smoothie or something would be fine. And fenugreek, I love fenugreek supplements. I think they work really well. So those are often my go-to, if we're just talking about PCOS optimization and lowering insulin resistance. If someone is also trying to ovulate and conceive, then I would suggest myo-inositol or some kind of inositol combination of myo plus D-chiroinositol. There's many more than that. I'm just, these are the ones I mentioned probably have the most data of the bunch. I mean, vitamin D supplements also, I think that addresses a lot of issues, not just PCOS. I would go with vitamin D as well.
I'm going to try to get to a few more questions here that are in the chat. They keep popping in when they're growing. All right. So another question is about hidradenitis suppurativa. Is PCOS a contributor to that, or is it related in any way? Dr. Zubritsky, I don't know if you're able to answer this one.
I'm not aware of any studies that totally link the two, but there are more and more studies coming out showing that HS can be potentially related to dysregulation of hormones in the body. We do know that there are some patients who do respond to spironolactone, metformin, and birth control pills. So it doesn't help in every single patient, but there are connections. And I think that, as we learn more and more about it, we might be able to see a connection between the two.
Okay, great. And I'm just going to try to go through as many of these as I can since we only have about 20 minutes left. So I was diagnosed with PCOS based on LH and FSH ratio acne and I can never say this word, hirsutism. However, I don't have irregular periods. Should I get an ultrasound to see if I have cystic ovaries? Love to hear thoughts on that.
I can jump in there. Rachel, do you want to say? Rachel's about to talk, Dr. Gerber.
What I will say is that, it sometimes does, we would say yes, that's part of the diagnosis and it would be an important thing to look into. That being said, I know as an adolescent or in patients who, let's say, have, are virginal or haven't had a transvaginal ultrasound before, you can actually make the diagnosis without an ultrasound in adolescents and in a population who, is difficult to tolerate a transvaginal ultrasound. And so I'd say, although in special cases, it's not 100% necessary for your average adult patient, it's definitely part of the workup and I would recommend it.
And what is seed cycling for PCOS? I actually don't know what that is.
I have not heard of it either.
I don't do seed cycling, but yes, it's a naturopathic approach to regulating cycles. And
what is it? What does it mean?
Ovulatory cycles. I probably shouldn't be the one to, like I said, I have some patients who see me and they see naturopaths and a lot of the NDs will use seed cycling. I think that they're told to consume certain seeds there's a protocol for it. So I'm sorry, really, I don't want to say, anything, but it's a naturopathic approach. I don't know how effective it is, but it's one of the natural approaches to regulate cycles.
I was just going to comment real quick on the polycystic ovaries, because I do get a lot of patients terrified that they have cysts in their ovaries. And that is a bit of a misnomer when it comes to polycystic ovary syndrome. They're terrified because they've been told that they have all these cysts.
Right.
It really should be called like polyfollicle syndrome. Yeah. It just means that you have more little eggs in your ovary, that when we look at them, we normally should see these little follicles where they house the eggs that are put out for that month. And in PCOS patients, they have more than average. And so for most PCOS patients, they literally just have more eggs than everybody else. And so it's not like on ultrasound, I think they're worried we're going to find something bad, like these, we hear cysts and they go to cancer and things like that. So I just want to be very clear that we're talking about polycystic ovaries. We're talking about ovaries that just look like they have more eggs than average.
Very counterintuitive, because you would think that someone who has more eggs doesn't have any fertility issues, but I guess
they're immature follicles. Yeah, and they're not properly matured, so they don't result in an ovulation.
There was a question that I believe Dr. Gerber was going to answer about endometrial cancer and PCOS. At what point is it appropriate to screen for ovarian cancer in a PCOS patient? I know often with ovarian cancer, it is found later stages than earlier.
Yes. So I think that, I don't know if this patient was talking specifically about ovarian cancer or, the cancer of the uterine lining, which is endometrial cancer. But as Dr. Provost mentioned, These cysts, they're not actually cysts. So a cyst is a solid or fluid filled, pocket within the ovary or so
Oh, we lost.
ultimately pocket of fluid, but it contains an egg. So that is what differentiates it from a cyst, which is just a pocket of fluid without an egg, right? So these are actually follicles, and they don't put you at increased risk for ovarian cancer. So that's not something you specifically need to worry about with PCOS. In fact, if you have PCOS and you're on birth control for long periods of time, like 10 years or greater, actually protects you against ovarian cancer. So that's a nice little added bonus for patients who are on PCOS on birth control for long periods of time, as many people with PCOS are. What PCOS does put you at risk for is endometrial cancer, which is cancer of the endometrial of the uterine lining. And ultimately, that's because what protects the endometrial lining is the hormone progesterone, and progesterone is the hormone of ovulation. So if you don't ovulate and you don't produce progesterone, you don't have that hormone that kind of keeps the uterine lining in check and keeps it from growing out of control. So ultimately, what we do is if someone has gone long periods of time without having a period, and we're suspicious that they're not ovulating, we will, when we see them, do an ultrasound, look at the lining of their uterus, get an idea of how thick it is, and even potentially go on to do an endometrial biopsy if the lining looks thick and you're giving a history that you haven't had periods for a long period of time, to just see, is there any precancer or cancer in the uterine lining.
Awesome, thank you. There's another question here. This is for Dr. Zubritsky. For the dark patches that can happen due to insulin resistance, what are some tips on managing those?
I'm assuming with that question, they might be asking about acanthosis nigricans, which is something that we haven't touched upon. And that is not just seen in PCOS. As you know, it's also seen in diabetes, insulin resistance. It can be seen with certain medications, malignancy. So just because you have that doesn't mean you have PCOS. But regardless, it is something that we see in this condition. Of course, the most important thing and the best way to get rid of it is to address the PCOS and the insulin resistance and the diabetes. So with that aside, if you want to treat it topically and locally, what I do recommend are things like tretinoin can help to lighten the skin. If it's irritated, you can even use like a topical steroid. You can use AHAs or BHAs that help to exfoliate the skin, lasers or dermabrasion.
And for lasers and dermabrasion for things like a medical condition, is that covered by insurance? I know it's slightly off topic, but I've never,
Yeah.
I don't know if that is.
Usually not. There are not many insurances that cover it, unfortunately. A lot of conditions, unfortunately, are considered cosmetic. Even something like vitiligo, which is very devastating to people, things aren't covered, even though it is not cosmetic whatsoever. But yeah, I've never really seen it covered, unfortunately.
Yeah, that's really, I was just thinking about that when you mentioned it also with like the hair growth. I'm like, wait, like that's not fair.
Yeah.
That's not fair that it's not covered.
I just wanted to add something about the acanthosis. It's because it's being driven by insulin resistance. It can fade and improve with improvement in insulin resistance markers. So if you're taking metformin, if you've lost weight, you're eating the right kind of diet, low carb or low sugar, low refined sugar diet, you will notice those marks fading. And it's an inexpensive way to go around doing it.
All right. I think we're about 15 minutes left. So there was one question that I had that I forgot to ask, but about birth control for PCOS. Does it matter if it's the combined pill or the progestin only, or does it have to be the combined pill?
Having more estrogen in the pill will increase your sex hormone binding globulin, which is this globulin that binds extra hormones that are circulating. And if you can increase that, you'll bind more of the testosterone that's circulating and kind of have an effect to bring that level down. So having a combined pill can help, although you've got to find the right contraception for the patient. And you have to take all of these things into mind when you're picking the right contraceptive for someone.
All right, awesome. This is a question. Is there anything that someone can do to avoid the possibility of getting PCOS? Is it something that is like preventable? Or I guess the real question is like, why does someone get it?
I'll take this one. I get this question a lot because I'm making this initial diagnosis at a time when it can feel heavy. It's what I usually say, and what I've read. It's multifactorial. It's one of those things that I cannot say this is the cause of why this person got PCOS and this person didn't. It can run in families. It can be associated with weight. It can be not associated with weight. And so what I like to do when I'm making the diagnosis is frame it as it's a chronic condition, just like asthma, just like diabetes. It's something that's going to be there, and we are going to be there with you to manage symptoms and to protect you from things that have risks that are associated with this condition, like the risk of developing diabetes or having cholesterol issues related to the insulin issues. So that is usually how I will couch it, as a chronic condition. Puberty is this weird time where you actually have a little bit of insulin resistance. And that's why it's actually tricky to be using that as a measure of whether someone has PCOS or not. And that's why we don't actually jump to looking at that, because so many things can cause that. And just puberty does, and it's normal. So, but what it does do is it's a sensitive time to declare that you have polycystic ovary syndrome. It kind of flips it. And so that's why sometimes in puberty, you might see the presentation, and some people present with polycystic ovary syndrome later, but I definitely want to get the message across that there's nothing wrong with them. They didn't do anything wrong, and it's a chronic condition, and just normalize it, and that we'll, as a team, take care of it.
Yeah, no, very, very helpful. Thank you so much. Do hormonal IUDs provide any protection from cancers like the birth control pill?
Absolutely.
Yes, absolutely it does. And in fact, hormonal IUDs, if you actually develop precancer or cancer, like early stage cancer, you can actually treat that with the hormonal IUD as well. So I'm a big fan of the hormonal IUD. It also provides excellent contraception, like pregnancy prevention. It does that better than the pill, and does a really excellent job at protecting the uterus from endometrial cancer. So I would give it a thumbs up.
Any skincare products that we need to be wary of for PCOS? Are there any ingredients in skincare products that we should look out to avoid?
There's not a ton that you should avoid, but I do recommend avoiding anything that's super occlusive. So anything that's going to, sit on top of the skin and not let it breathe per se, like something that's petroleum based or something that's comedogenic. So the best thing that you can do if you're going to try to treat it and use skincare products on your own is to look for oil-free ingredients. It should say that really clearly on the label, non-comedogenic, non-acne causing. So you don't want to do anything that's going to necessarily worsen it.
Okay, awesome. If a patient gets pregnant and is on metformin for her PCOS, do we have to switch that person to insulin? No.
So
Uh-oh.
Oh, Rachel's frozen.
yeah, I would say better question for your high risk pregnancy doctor or your OB, but metformin is a fairly well medication in pregnancy that people with gestational diabetes frequently use. And so, I wouldn't necessarily say you have to stop it, but it's something that you would want to discuss with your doctor and at your initial prenatal visit.
And is having PCOS or being on metformin sort of an automatic buy into a high risk pregnancy, or not necessarily?
Depends why you're on the metformin. If you're on the metformin for a diagnosis of diabetes, then yes. If it's for like an insulin resistance or pre-diabetes, not necessarily, but what they would do is give you a screen for whether you have gestational diabetes, because being pregnant actually puts you at an increased risk of getting diabetes when you have a baseline of insulin resistance. So that's something they'd want to test for early in pregnancy, just to make sure that you're not developing, a full-on diabetes when you started with insulin resistance before you were pregnant.
One more question here. This is actually a really good question. We've been saying diet and lifestyle. Can we be more specific? So I'd love to hear what our panel has to say on some specific things that people can do when they talk about diet and lifestyle. It's very easy to say, oh, just, change your lifestyle. It's like, what do you want me to do? So I would love to hear anyone's or everyone's thoughts on sort of, and just try to keep your answers short because we're 8:52 and I do want to sort of have some time to maybe hit one more question if we can.
Okay, I'll try to be quick about it because I think I'm the one who mentioned it a few times. So, primarily, you want to eat in a way that's not going to trigger insulin response. You want your insulin levels low and steady. So to do that, small, frequent meals would help rather than one massive meal, at the end of the day. The other approach is also to limit carbs, starchy foods, refined sugars. Those need to be cut out. If you're having carbs, it should be more of a complex carbohydrate with high fiber. The focus needs to be mainly on protein intake. You need to have a good amount of protein with your meals and some healthy fats, like not saturated fats, but the healthier fats like avocado, nuts, seeds, olive oil, but primarily protein and a small amount of carbs. I mean, that's the basic diet in a nutshell. If you wanted to go keto, that's fine. I would work with a nutritionist on that, and that's more of a seasonal diet. You do it for a few months. If you want trying to jumpstart weight loss, that would be fine. But the long-term diet plan is a low carb, low glycemic index diet that's higher in protein and healthy fats, eaten as small, frequent meals through the day rather than one or two massive meals. Oh, and lifestyle, exercise, low to moderate intensity, even if it's 2 or 3 times a week, get used to having some regular exercise. That helps tremendously as well.
Right. Anybody else?
One thing that I would definitely mention is that for all my PCOS patients, I do recommend talking with a nutritionist. We have one available on staff at our practice, and nutritionists are really great because they can actually listen to like what you normally eat and actually make adjustments that are personalized to you. Everyone has their different favorite foods or maybe a favorite restaurant. And I find, and I've been to nutritionists myself, they will really be practical about it because, it's sometimes hard to just say, cut carbs or this or that. So for example, I was eating yogurts in the morning and thinking that was healthy, but my nutritionist that I went to at one point told me, you have to look at the label, find one that's high protein and, that doesn't have a high carbohydrate. She told me which brands to look for, and now I have these brands yogurts that there tend to be the Icelandic Skyer yogurts. So this is one thing I learned, and this is what I eat for breakfast pretty much every day now. She also would teach me, like, for example, I had a nighttime snacking habit, and so she would say, it's great to say don't eat after 8 p.m., but if you and your partner, that's your lifestyle, let's actually replace it with something that's healthier, not just cut it out, because maybe for a couple months you can cut it out, but it's going to be hard to continue. So she gave me suggestions, try and snack on nuts at night, or she gave me these ice cream bars that were low, that had a low glycemic index. And I just found it was really great. I saw her 2 years ago and I still every day think about the things that I discussed with her because she gave me like a very personal approach. And so I would really highly recommend that to everybody.
Awesome. Thank you. I think this question is going to be a astounding yes. I am thin. My sister has PCOS. I personally don't fit the classic picture of PCOS. Can I schedule an appointment for a PCOS workup based on personal suspicion alone? What say you, panel?
Yeah. Yeah.
Yes. That's a big yes from everybody. Yes.
Very, very high chance, when it runs in the family.
Please, and you're always welcome to see your doctor. I think that's what we're here for. So please.
I think
Yeah, sorry, someone had
I
said.
think there's a big misunderstanding, even in the medical community. I think as a whole, we're victims to this, which is that looking at PCOS as being associated with metabolic syndrome and obesity. And I see in the fertility world all the time where thin women they've just missed it and not really asked them about their periods and stuff like that. And BMI is not associated with the diagnosis of PCOS. We do tend to see it more in the kind of extremes of weights for other reasons, but it is not necessarily associated. We see more symptoms in women that are obese because they have more adipose tissue, which makes more estrogens, which gets converted to more testosterone. So they have overall more outward picture of that high testosterone level, more acne problems, more hair growth issues. The thin women don't often have that same appearance and don't often have those symptoms, taking them to see their doctor earlier in life. It's just really important to understand that.
Yeah, that's great. That's great to know, because I definitely did not know that PCOS, happened in people that didn't have that sort of classic clinical picture. So that was news to me when I sort of realized that a year ago. Wow. Okay. So we're 8:57. I want to give all the panelists a chance to just sort of, what is your parting tip? Real quick. What would you like, the audience to know, and everyone who's going to watch this later, just about PCOS, and if there's any sort of thing that you can leave with us today. Dr. Provost, do you want to go first?
I think just that it's manageable and it's treatable, and if find the right team and the right physician group, support group to help you manage it, because if they're not helping, then you need to find new people to help you. Absolutely.
Yeah, there was actually a question in the box about who makes up the right care team. Well, I think you're looking at some pretty awesome doctors right now. Definitely someone to manage your hormones, obviously an OBGYN, if you're thinking about fertility in the future and you're concerned about it, an REI specialist, and a dermatologist who can help you with some of the outward hormonal changes. So I think that those are, there's so many people that you can involve in your care. And nutritionist, Dr. Gerber also mentioned nutritionist, which might be a really good addition as well to your team. So definitely everyone on every type of doctor that's on this panel. Dr. Gupta, what's your parting tip for everybody?
I would say it's important to know that PCOS is such a heterogeneous condition, and women have different presentations, different phenotypes. You could be lean, you could be obese, you could have different symptoms affecting you, some intense, some mild. So the treatment plan also has to be customized. So, you need to have these conversations with your doctor. The doctor needs to listen to you and pay attention to what are your main concerns, so we can address the main concern first, followed by the minor concerns. For instance, is it more cosmetic, acne, hirsutism? Is it the weight issue? Is it ovulation and fertility planning? Because we may not be able to address everything all at once, but we have to pick and choose what is the primary concern. So not everybody needs to be treated with this holy trinity of, birth control pills plus spironolactone plus metformin. You might pick and choose, or you might have a fully natural plan with just weight management and diet, or you might have a combination. But it's all about what your needs are, what you're comfortable with, and also what are the main symptoms you want to address. So these conversations have to be very frank between you and your physician or your care team.
Awesome. Dr. Zubritsky?
So it's very important to be on the lookout for the constellation of symptoms and the cutaneous manifestations of PCOS, because it can be the first indicator that you have it. And it's more than just severe acne. It's also hair loss, hair thinning, hirsutism, unwanted hair in places you've never had before, as well as acanthosis nigricans, which is velvety dark plaques on the skin, or even skin tags. So all of those are reasons that you should go and see your dermatologist immediately to get a diagnosis of PCOS if that's what you have.
Yeah, and the one thing that stood out to me when you were talking about acanthosis nigricans is that it can be a sign of some of the other, things that you mentioned. So you want to involve a doctor. Definitely if you have these skin patches, go see a dermatologist, because if it's not PCOS, you want to know what it's happening from, because it is not a normal finding. So
Correct.
definitely want to get it investigated. Don't just, we're so happy to be here and give you all this education, but please don't assume that you are going to be able to self-diagnose anything after this panel. Please just involve a physician who can get you to the right place. Dr. Talib, what is your parting words?
Parting words. It used to be back in the day that we thought, oh, girls can have irregular periods for 3 years after starting their first period, and it's okay, it's normal. That is out the door now. And we are diagnosing polycystic ovary syndrome at younger and younger ages. Even a year after having their period, we're able to say, I think they're at risk because they have family history or they have some of these other signs. And so if there are signs, if there is a family history, if it's your kiddo, I know there are a couple of parents in the Q&A, look out for it, don't miss it. I like to diagnose and treat it early. And I do like to speak about, with adolescents, it's this blend of different from some of my other panelists here, where we think a little bit more about contraception than about fertility. But I always like to have the fertility conversation at the same time that we're making the diagnosis, so that it's a little bug in their head, in their parents' head. And so I think that part's important and sometimes can get missed when people are laser focused on contraception.
Yeah, no, that's a great point, because the earlier you know about, that stuff, the more you can wrap your head around it and start to make educated decisions for yourself. And before I get to Dr. Gerber's final tip, everyone, again, just check out everyone's handles here. Be sure to check them out on Instagram. Everyone is an amazing educator. I learned so much. I never thought Instagram would be like a way for me to learn medical education, but it really is now. So be sure to check them out. We also have some of our doctors that are also active on TikTok, if any of you are on TikTok. And Dr. Gerber, what is your parting tip?
So my parting tip, I have 2 quick tips. One is don't be afraid of the birth control pill. I feel like people are often worried, am I on it for too long? Is this going to lead to problems with fertility? The answer is no. It treats PCOS very well. You can be on it for as long as you need. And when you're ready to have a baby, you can come off and you come to see a fertility specialist if you have or talk to your GYN if you know you have a history of irregular periods. And our treatments are really, really excellent, and we can do a really good job at getting you pregnant. While patients who have too few eggs, there's not as many options for them. PCOS patients, almost like they have too many eggs, and for them we have plenty of options that are not expensive, and just know that the outlook is good, and that we can very likely help you have a baby.
Awesome. Well, I just want to express extreme gratitude to these extremely intelligent and generous physicians who have given their time away from their family and away from their personal lives to help answer all these questions. I know we left a lot of questions unanswered. I will definitely be trying to organize another event. So please check it out. You can also, DM us questions at FemHealth Project. We'll really try to get you guys as much information. We'll also be posting more articles about this on our website as well. I know it's an underrepresented topic, so we are doing our best. So thank you all for being here. A huge, huge thank you to all the doctors. Getting, like I was saying this before the attendees joined, but getting 6 doctors in a room for an hour is a very challenging thing. So I appreciate everyone being here, and good night.
Thank you as well.
Thank you so much for
everyone.
organizing this.
Thank you.
Awesome.
Great seeing everybody.